body gets ready knowing they're gonna have a blood loss. Also, again, this is the importance of why baselines are so important. This is why prenatal care is so important.
Sorry, Leslie.
Thank you.
Is your thought?
What is that? I want to hear my voice. All right. So again, knowing what that baseline is. That's why we hope they come in and they're all happy in the early stages, because that's going to give us the baseline then, versus if they come in 9 centimeters, screaming, hurting, different things like that, right? You are going to have an increased WBC count. Why? Inflammation, right? Inflammation, different things like that. So that's going to be a normal adaptation. Now, again, you're going to also have an increase in the postpartum phase because you just went through birth and even more inflammation, okay? So again, looking at that, we're going to look at increased respiratory rate and oxygen consumption. That's why it's important we're monitoring this fetus during this time, because if mom has an increased oxygen consumption, what does that do to the fetus? It decreases the amount that they can pass to them. So we have to be making sure that they're oxygenated. We already talked about the decreased gastric motility, food absorption, right? Decreased gastric emptying. That's why we don't want to feed them a lot during labor. Usually most women, by the time they get 4 centimeters, they're on just sips and chips. And I will tell you another funny story. So I was precepting a new grad in labor, and she said, the patient wants to know if she can have something to eat. I said, nope, all she can have is sips and chips. And she's like, okay, I'll let her know. So she goes in and tells her, and so I come behind her to check, and the patient's sitting on the bed eating a bag of chips. And I'm like, what are you doing? And she's like, oh, the nurse told me that I can have sips and chips and brought me a bag of chips. Do you guys know what chips means? Ice chips, right? I told the nurse, I was like, seriously? And she's like, you told me sips and chips. And I'm like, not Doritos. We don't get to eat Doritos. No food. And why do we not feed them? Because the delayed gastric emptying and the decreased peristalsis, because we don't want them to vomit. And if they have to go to a C-section, we want nothing in their system. Okay, so that's the whole reason behind it. Not that we're trying to starve them by any means, but we don't want food sitting there. And who really wants to eat a heavy meal when you're having contractions, right? No, it's no fun. They may have a slight temperature elevation. Again, what do we need to know first? What the baseline is. What did they come in, okay? You may have, again, muscle cramps, aches, also because that's that relaxin, opening everything and getting them ready, increased metabolic rate, and so all of this is happening during this labor process. With your fetus, you might see periodic fetal heart rate accelerations and slight decelerations, and that's all in relation to what? Their oxygenation. So if we know mom is consuming more than she was before, we're going to have these little dips. If baby's happy during a contraction, we're going to see a nice little acceleration, right? And baby should be moving all around. And that tells us that there's a reserve. That tells us that they have good oxygenation, okay? All right, signs of labor. So lightning. What is lightning? Let's think about this. Anyone ever seen someone who's third trimester and they're carrying like this, and all of a sudden they say, oh wow, the baby dropped. Yeah. That's lightning, okay? Lightning means the baby went down, and what is the baby getting ready to do with lightning? It's getting ready to come out, okay? The baby drops down, and that's the baby getting ready to start making these changes. Also, you're going to have that increased level of activity or nesting. Who knows someone who nested and got the house all clean, and they're like, every outfit I bought from 0 to 12 months is now clean and hanging in the closet. Yes, you have these first time out. And then when you get to your second, you're like, I didn't wash one thing. And then you get further on, I hear, and you don't do anything, right? I can tell you with my daughter, I had every month, we did a professional photo shoot with my daughter. My daughter had more pairs of shoes than probably half of you in this room at 6 months of age. My mom bought her shoes and hats and dresses, and she's the first and only granddaughter. That tells you right there, right? She still buys her. Just bought her a $4,000 wedding dress. Yeah, I'm like, wow, yeah, I did not participate in that one. But every month had a professional photo shoot. My son, we started, missed a month, skipped a month, over here. So I have like little fill-in pictures, no professional, right? So it happens. All right, so you have that level of activity. Pass them out.
Thank you.
Best thing ever was 99 cents store going out of business because I got new ping pong balls. How many more do we need over here? Yes. You have one back there. Anyone else need one? All right. Do you want? Think fast. Are you having a boy or girl? Boy. You want a boy? Girl. You want a boy?
I want a girl. I want a boy.
You having a girl? Girl. Girl. You're having a boy. What are you having back here? Boy or girl? You want a girl? You want a girl? Girl. What are you guys having?
A girl.
Pass it back. Who wants a girl?
Me.
You want to pass that back to him?
You want a girl?
Girl.
Girl. Boy.
Boy.
I want nothing.
You know what girls are? Your broke best friend who thinks you're rich. That's my daughter. That's what girls are. That's my daughter. The only time I get a call from my daughter is when she needs money. Alright, I'm gonna have a boy because my boy's my kid. Okay, so what you're gonna do, you're gonna open your balloon and you're gonna put your ping pong ball in your balloon.
Yeah, it is. See, I was like, look.
Like all the way in?
All the way in. Yep, it's gonna go all the way in.
Oh, shit.
Oh! Did you break your balloon? So it's gonna go just like this.
Oh, my balloon broke.
Placenta.
Placenta
Placenta.
Broke the placenta.
You killed your baby.
No.
Is that like science?
Open it and yeah. No.
Pop your balloon.
Oh, I lost my baby.
Another balloon.
So stretch it really good, and then put the ball. I want to hand that back to him. You broke it too?
Yeah. How did you get it in? I gotta wait. Can somebody do it for me? You guys stick your finger
You all the way in and push it to the back of it. It should be just like this to the back of it. You need another one? Help a friend. Help a friend. Here.
Do I need my...
Okay. Anyone else need a balloon?
I broke my tip. Is that okay?
You broke your tip? You probably have an incompetent cervix. So
That's not a good condom. That's not safe. She broke the tip.
okay.
How do you get it out?
Okay, so if you have it like this, it should be at the end like this. You're gonna just blow it up. You're gonna hold it, and you're gonna get the ball into your birth canal. So push it down in there, and it should stay there.
Oh, no.
Push it down in there. Should be just like this. You good?
I have a
Get
defective
down in
balloon.
that tip.
I have a defective balloon.
Perfect, just like that, just like that. Like. Yeah, there's no way I'm doing this. 40 minutes. Okay. All right. So this is a visual that shows you. So what are Braxton Hicks? Fake contractions, right? And what happens with Braxton Hicks? They stop when you change activity, hydrate, right? So take your balloon and squeeze it from the side. These are Braxton Hicks. Do you see, this is my cervix, nice and thick down here, right? Nothing's changing to the cervix with Braxton Hicks. Now, where should contractions happen? On the fundus, at the top. Now, when I have real contractions, what happens to my cervix? With real contractions, I just efface, dilated, and delivered. Okay? So, you go from the side, that's fake. You need to go from the top. Oh, he just delivered. We have 2 deliveries. Yeah, just keep going. We had a delivery, okay? So you can see, you had a uterine rupture actually. So you can see when you push from the side, nothing's happening. Those are fake contractions. When you have contractions at the fundus, you're going to have cervical change and cervical dilatation, okay? Yeah, a lot of you had Alright, so again, you can even do that at home. That gives you a visual, and you're having a dystocia. You're having a dystocia, right? Something's not working with your passenger, your power, something. So if your balloon popped, your uterus isn't functioning properly. If you're not dilating or having effacement, we have a problem there, okay? So again, this is just a visual to show you, with your Braxton Hicks, nothing's gonna happen. With true contractions from the top, you're gonna make cervical change. And that's the difference between false labor and true labor, okay? All right. Bloody show or ripening of the cervix is another thing you're gonna start seeing. As that cervix ripens, you're gonna have some bloody show happening. Rupture membranes, again, is a sign of labor. If it's premature rupture membranes, we want to hold them off as long as we can. But again, that's a sign that the body's getting ready. And then cervical dilatation. All right, so this is kind of a chart that we would teach patients. Is it time to go? Is it true or is it fake labor? Okay, false labor. So you're going to look at your contraction timing, you're going to look at your contraction strength, your contraction discomfort. If someone comes in and they're like, yeah, I'm contracting and I'm ready to have my baby, they're not ready to have their baby, right? They're on their phone. But if they can't talk through them and they're stopping and they're like, really? Then they should probably be evaluated, okay? We never triage patients over the phone. Our recommendation is come and be evaluated. All right. I would start with the most critical. All right. So this, I love the music too. I think we have to have the music. It's not the same without it.
Is this real?
Yes.
No. That's not good.
Oh man.
Unless it just got wax.
I guess I'll have to talk through it. The music, it's like someone, whoever put this video together, you hear the song. So this is the baby crowning. I'm going to talk you through my little. So that is the baby's head. That is Vernex all over the baby's head. That's the white cheese that's all over. And what's happening here is vaginal stretching. So every time they have a contraction, they're going to push, and that head should stretch a little. In a primate, it's going to go down and back up, and that's normal. This is called the ring of fire. If this woman does not have an epidural, it feels like her vagina is on absolute fire at this point, okay? So this baby's head, this is normal. We're still monitoring these contractions, but this is the baby crowning. You can see she has some hemorrhoids down at the bottom from all that pressure of that baby's head sitting on that perineum. And it keeps coming out. Okay, the music, I gotta find it. Okay, so you see what position is it in?
Down.
Head down. Now it did an internal rotation. So this is going to be the head out. That's amniotic fluid squirting out with blood. You see the pressure that they have to put on the head to get the shoulders to be removed. That's the cord around the neck. It's called a nuchal cord. So they try and slip it over. Again, this head can stick out and we have to wait for the next contraction because we don't want mom to push without the primary power. The cord is so tight on this video that they're cutting the cord before the baby's coming out. They can't slip it over the neck. In a loose nuchal, they can just slip it right over. This is pretty tight for them to have to cut it when the baby's still at the perineum. Watch the pressure they put on this baby to try and get the shoulders. Once the first shoulder dislodges, usually the baby will just fall out.
Can they break their neck?
They don't, they're very durable. Everyone wants to go have a baby now. See how the baby's limp and blue, and now we wait for initiation of respirations. Okay, I have to figure out.
So now we're going to make a suggestion that you bend your knees and soften your elbows.
Okay, so again, this is from the 80s, but it's a good video. She's in the latent phase. This is early on, not dilated yet kind of thing. This nurse, I'm like, watch so many things she does wrong. Half the time she doesn't wear gloves as she's touching bodily fluids. But she's very, very all about the patient.
That's great, thank you. Thank you. Lisa, how does that feel? It feels good. Any kind of contractions that you've been in there? I don't think so. Okay. Oh, now there's, okay. Very large in here. You're going to do the same thing that you did before. If you want to turn over and close your knees, you can do it. Okay.
Yes, they moan like that. They make all kinds of noises.
Church, we're not sitting on the wall cushioning it, something. So,
Listen to her.
we're going to do the same thing. So now think for a minute. Yeah. And you put a little turtleneck jersey on your
A
side.
turtleneck jersey is what she's saying the cervix is like.
And you gather up the neck of the collar.
Yeah.
And you start to pull it down over his head. And that turtleneck starts to open up. And it starts to open up.
I've never told my patients their cervix is like a turtleneck.
You see right on the baby's head.
Yeah.
She's giving her a visual, that's the purpose, right?
Start to have that contraction. Send all the energy right down to your cervix. And stretch that cervix just like the turtleneck jersey coming down over your little bag's head. And this is your little girl's head. So I'm being very optimistic here, and I think we're going to have a baby.
So the transition used to be 8 to 10
Not
centimeters.
anymore.
So you gotta watch the dad as she's pushing.
Lisa, are you feeling any pressure? I don't know in this water. Oh,
They don't know anything at 8 to 10.
It feels different. It sounded different. How did it feel?
Just, it was so intense.
Okay. Are you feeling anything lower? I don't know. Sorry, I don't.
That's all right.
I don't.
Okay. Sound like you can stay in there a little bit longer?
Maybe so.
Very therapeutic voice.
You're doing such good work. You're doing really. Tell me when to stop. Oh. Okay. You feeling started? I think so. All right. All right. We're gonna put your legs back. That's it.
That's the most ineffective pushing. She's pushing in her face, but there's the baby.
That's it. Beautiful. Again, deep breath in and push.
And that's the ring of fire.
That's it. That's the way. Again. A lot of burning. A lot of burning. Just push past it. That's it. You're doing so great. Okay, now just like that. It's stretching. It's stretching right back.
So you notice how it goes back in, right? That's normal. Just keeps going until it comes out.
Okay, we're just gonna put a little green soap on the baby and kind of.
Alright, that's good.
So we put baby shampoo on the baby's head to try and lubricate it to help push it through.
Okay. Alright. Yes, that would be great. Thank you. Alright. Okay. Okay.
Now watch this, Dad.
Come on, Dad. Don't pass out, Dad.
He looks scared as hell. Look at his face.
She's like, I'm never going there again.
Excellent.
So as a student, you can hold their leg just like that and be all up in their business.
Can you tell him not to scream? Like, can you tell him not to scream?
We try to. It's not effective. She's using too much energy screaming. But she obviously has no epidural.
Okay, my head is out. You wanna look? Does he like your husband? So she's gonna come up, brown ear, pixie haircut, brown eyes. Okay, so they put this section around her mouth and nose, and
And then watch the pressure they put on this head to try to get the another nuchal cord.
Okay, now push her out the rest of the way.
So this is the shoulder dystocia. The shoulders are stuck. So they're going to take Robert's maneuver and pull her legs all the way back and suprapubic pressure to try and pop the shoulders out.
Go ahead. Breath in.
See the hand underneath is coming out? So lay her back, pull the legs all the way back. That's McRoberts. And she's seeing her hand on the pubic bone.
Is she tear at this point?
She's torn at this point, yeah. Baby's floppy. There you go. Okay, and then I have one more, and this one is a C-section.
In the labor and delivery unit at Community Regional Medical Center, Dr. Ron Lichtenstein is a repeat customer.
This is a lady who's had 9 kids. She's going to be baby number 9. She's had 3 C-sections, so we're going to do another C-section and hopefully without any complications for the rest of the baby.
Stephanie Falcon and husband Abel are about to
So
welcome
anything
Ken
over
into the
2
world.
is dangerous, 3rd, 4th, it gets even more for uterine rupture.
Sweetie, shake it out, please.
Because of her post-cesarean section? Because of her previous cesarean section?
Because it's scar tissue and all that.
Looking to get the baby out, more bleeding, damage to other organs, damage to the bowel, damage to the urinary bladder, and doing a 4th C-section is really, really scary.
Dr. Lichtenstein heads into surgery, and all Abel can do at this point is wait. Stephanie and Abel Falcon are expecting their 9th child. This will be Stephanie's 4th C-section.
I like the challenge, and the day of something takes care of those will be blessed up in surgery.
Perfect, ready.
Ready, Stephanie? All right. So
They're
let's go
awake
for
during
it.
the whole procedure.
Okay, we've gotten to the fascia, and this is where we'll start seeing in if we have any.
The fascia is a layer of fat which lies above the abdominal area.
Okay. Big vessel here, looking at the hemostat, please. Now I got to the fascia, which is the main abdominal wall, which is actually what's closing the belly, keeping everything inside. And we're going to go through that, and then we'll find out how we're doing in terms of scar tissue inside. That's not the only one. Okay, some more fascia. And now 2 straight pokers. One to Dr. Plata, one to me. Going to separate the fascia from the muscle. May I have a knife, please?
Dr. Lichtenstein can't get into the uterus without cutting through this tough fibrous layer.
Again, making some room for the baby here. Separate the top of the fascia from the muscle. Let me have the knife again, please.
Stephanie's husband, Abel, is now by her side, comforting his wife and soon-to-be new mom.
All right, now.
And then they just rip it
How
open.
are we doing in terms of scar tissue? Gently. And this is the scar tissue that we were talking about right there. So we're going to try and get it down a little bit. Let me have some mesh, please.
What's that? Scar tissue from her other?
Previous sections.
And that's from the previous C-sections. So what I'm doing is I'm separating it from the uterus. That's the bladder here, that's the uterus, and they're connected to each
See how
other.
close the bladder
So I'm
is, so
cutting
they
it
can
apart,
pick it very
bringing the
easily.
bladder down.
Dr. Lichtenstein has run into a potential problem.
And let me have Alexis, please.
Scar tissue from Stephanie's previous C-sections is making it difficult for him to access her uterus. He must work quickly as the baby needs to come out.
In the labor and delivery unit at Community Regional Medical Center, Stephanie Falcon is having her 9th child by cesarean section.
As Dr. Ron Lichtenstein is cutting into Stephanie's uterus, he is encountering scar tissue from her previous C-sections.
So from the previous C-section, I said the bladder is sticking to the uterus. So I cut between the two, and we're able to separate it pretty easily. And put my self-retained
So this is a
electric
ring that we
in
use
here.
as well sometimes, and it keeps it open versus using the retractors, the metal retractors. And that's the uterus right there.
And are we ready for baby here? Not please? That's the uterus here. So that's where the baby lives for the next few seconds.
And watch the pressure they put on her
Opening the
stomach.
uterus, get to the baby's head. Dr. Papa is going to put some pressure.
That's the sac.
That's the water bag here.
There it pops.
And rub her head. And oh, welcome to Fresno.
Another nuchal cord.
Good baby too. Woo! And it's a boy.
Nice thick cord, so it had good oxygenation.
Dr. Papa is going to take the baby over to Mona.
Stephanie's newborn has entered the world, but Mom is still awaiting a reunion with her little
It's a
one.
big chunky baby.
Baby Andrew has just entered the world via C-section. His nurses and doctors now make sure he is
It's
happy
big and
healthy.
cheesy, which tells you it was probably gestational diabetes, because that Burnett should have went away if it was full term.
New Dad Abel will cut the umbilical cord of his 9th child.
Now, Dad, see what's here, and I'm gonna hide it because. Yeah.
There were some concerns going in. I was worried about the adhesions. There were some adhesions. The bladder was attacked.
So you see, they have to cut through all those layers.
Why did he tear it instead of cutting it? Like, why did he just rip it?
They do all the time. They say that, well, they do cut, but then they tear to get it open as much as they want. They say it's a better healing, just like if your vagina tearing, it's a natural tear versus cutting more. Some providers cut tiny little holes and then they really have to tear, and we're like, just cut a little bit more. But yeah, that's pretty much. All right, so laboratory tests, again, we need to have baseline. So we hopefully have prenatal care. So HBsAg is your hepatitis status. We also want to know the RPR. HIV, as I've told you, they can opt out of because you do have to sign a consent. We wanted to do UA, culture sensitivity, all of that. We want to look at their urine. We want to look at everything, okay? Again, during prenatal care, we should be having these tests on a regular basis. Stages of labor. So we're going to start and go through stages and phases. So there are 4 stages of labor. And then in the first stage, you have 2 phases, okay? So again, our first stage of labor is going from 0 to 10, our dilatation, okay? Your latent is now 0 to 6 centimeters. So latent is a big portion of it because someone can be 1 centimeter for days and weeks. And so again, ACOG changed these definitions. So you may even see still in textbooks and on test banks, latent active transition, because a lot of, again, the textbooks were written before all the changes. So again, there is a change in that. However, for exam purposes, you're only going to be tested on latent and active, okay? Then you have once you become 10 centimeters, you go to the second stage. And that's onset of 10 centimeters to the completion of the birth of the baby. So baby comes out. Once baby's out, you then move on to the third stage, and this is your placenta stage. This is where the placenta is going to separate and come out of the vagina. Usually 10 to 20 minutes after birth. If it's later than 10 minutes, that is a risk factor for a postpartum hemorrhage. If it doesn't come out at 30 minutes, we have to start doing interventions to figure it out, up to a D&C to go and actually take out the placenta. Once the placenta's out, they go to the fourth stage, and postpartum really is after placenta 6 weeks, but we're only looking at the focus on the recovery, and that's the first 4 hours for the placenta, for postpartum in the fourth stage. All right. So, again, if we go back, what do you think is happening in this latent? That's when they're all happy, they can talk through contractions, not a whole lot's going on, until they get to about 4 centimeters, then it starts picking up. And then when you get to your active, a lot of times that's when they're in a lot of pain and different things. There is no criteria for epidural. It's kind of just depending on how fast she's going and what's happening. All right, so the first stage of labor, this was when it's ideal during this time to be able to get their history and physical. If they come in and they're 9, you're not going to be like, can you give me your gravidav and parity, please? Because they're not going to care at that point, okay? This is when we want to ask if they have any birth plans, if they do, what it is. I've had some crazy birth plans. I had one where in her birth plan she said that the nurse would rub her feet the whole time. I do not touch feet, even with gloves. I do not like feet, and I'm like, no, that is not happening, or I will not be your nurse. We've had some who they don't want an IV, different things like that. Again, we do the least invasive possible. Let us do our job, because when you come in with those, if we don't meet those expectations or you stall out, you end up in a C-section. It's kind of like, not really love, but when patients don't want male students, it always ends up in an emergency situation and the males come in anyways. Just let us be, right? All right. So you may also need to do Leopold's maneuver. Leopold's is how you figure out what position the baby's in without doing an ultrasound. So you want to go down low to figure out and feel around what side the back is. The best place to get the fetal heart rate is the baby's back, okay? Remember when we talked about fetal monitoring, and there's some here that we'll kind of do a quick review. If the monitor's down low, that usually tells you that they're head down, vertex. If you're fighting the toco and the ultrasound, usually it's breech, but the back is the best place. In the first stage, you want to check their membranes. Are they intact? Did they S-rung? Remember the Amisure is that test where we swab the vagina for a minute and we sit and talk, and then we swab in the solution for a minute to see if it is ruptured. If they are ruptured, we need to know the date, the time, the color, the amount, and if there's a smell. There should be no smell. If there's a smell of their amniotic fluid, that usually tells us there's an infection brewing, okay? We wanna also do a badge exam to see what the fetal descent is, presenting part, and then this is when we're gonna start monitoring their contractions. Again, frequency, duration. Who remembers our intensity? What is the only way to do intensity? 2 different ways. Either internals or palpation. When you palpate, what does mild feel like? Your nose. What is moderate? Your chin, and then strong is your forehead. But please do not be in there palpating, doing this, because the patient's gonna think you have an issue, okay? We talked about Leopold's. All right, fetal assessment. So fetal assessment, again, fetal heart monitoring, we have to do, you can have continuous, you can have intermittent, it just depends. But we need to assess the fetal heart rate every 30 minutes for at least 15 minutes during active labor. Usually what we do is we just keep our patients on continuous monitoring. Just because the adverse outcomes, it can detect it sooner rather than later. Everyone remembers we have external monitors. Those are the least invasive monitors. You have your ultrasound, which detects the fetal heart rate, and you have your topo, and that's gonna detect the contractions. What is the difference on the back of the 2? The button. And where does the button go? On the fundus, right? On the uterus. You have your internal monitors, you have your spiral electrode, and what is that? The little corkscrew that goes in the baby's head to detect what? Fetal heart rate. And then you have your intrauterine pressure catheter, or your IUPC, and that's that little tube that hopefully we can get all the way up to the fundus to get contractions internally, okay? So we already know, and you guys can review from what I went over, the benefits and the risk. This is showing you the best location to monitor the fetal heart rate is on the baby's back. So depending on the baby's position, we have to figure out the position, and then we just want to make sure that that ultrasound is on the baby's back to get the fetal heart rate. All right, so there are different categories of fetal heart rate patterns. Category 1 is normal. That's what we love. They're good. Category 3 is baby needs to come out, depending on what's happening. Everything else fits in category 2. We've asked ACOG over and over to break it out, because category 2 is what you're gonna see 99% of all labor patients, just because they're gonna have some type of decel or some type of something going on, okay? So just in your thought process, 1 is the perfect world, beautiful baby, 3 is emergent, and everything else fits in the middle, okay? All right, so what is our baseline? We're gonna do a little review. 110 to 160, and how long do we need the baby on to get a fetal baseline? 10 minutes, right? We need the baby on for 10 minutes. And how do we determine the baseline? Where often it hits on the line will be your baseline. What are the numbers for baselines?
0 to 5 is minimum.
That's variability. We said normal baseline is what? 110 to 160, and it's rounded to what? Increments of 5, correct. Increments of 5. So you can't have a 132 baseline. It's either 130 or 135, okay? Okay. Anything below 110 is? Brady. Anything above 160? 10, right? Okay. Variability, that's what we have now. So variability, we have absent. What is absent? Flatline, right? No deviation from the baseline, okay? What is minimal? 1 to 5 beats per minute off the baseline. What is moderate? 6 to 25 beats per minute off the baseline. And then what is marked? Greater than 25. It looks like a kindergartner scribbled, and you can't figure out a baseline. If it's marked, we gotta figure out what's happening to make it marked, okay? What is the best variability you can have?
6 to 20.
Moderate, and what does that tell you?
Oxygenation.
Oxygenation, correct. The fetus is oxygenated. All right, we also have periodic changes. What is the definition of an acceleration? Remember your veal chops. It's okay, accels are okay. And what is the definition, or what is the criteria?
15 beats. Baseline for 15 seconds.
So greater than 32 weeks gestation, 15 beats per minute off the baseline for at least 15 seconds. 15 by 15 is an acceleration. Less than 32 weeks gestation, they only need 10 beats per minute off the baseline, lasting 10 seconds, because neurologically, they're not developed like after 32 weeks, okay? So prior to 32 weeks, 10 by 10s, after 32 weeks, they must meet the criteria of 15 by 15. 15 beats per minute lasting 15 seconds. All right, what is a variable related to? When you talk about veal chops. Cord compression, correct. So variables are cord compression, and what does their variable look like? Carrot, right? It's an abrupt decrease from the baseline, abrupt right back to the baseline, okay? And that is all cord compression. I'm telling you, you will have strips. I will open practice strips that you guys can look at on your module. I also have a game from the NCC, that's who certifies us in fetal heart monitoring, that you can practice determining. Is a running strip that you can see to practice if you're right on minimal variability, moderate variability, and all of that, okay? I advise you guys to practice, because I think you will have 3 or 4 strips that you will have to interpret within the next exam and the final exam. All right, what is an early related to? Head compression, okay? An early is head compression, so what is that going to look like? They're in sync, they're gonna mirror each other, right? So do you have to have contractions with an early? Always, yes. Do you have to have a contraction with a variable? No, you do not, okay? So variables just happen because there's some type of compression to the cord. It could be the fetus lie or anything like that. To call something an early, you must have a contraction. So when should the nadir be in an early? The nadir is the lowest dip in the fetal heart rate deceleration. So the nadir should be at the peak of the contraction, right? That's because they're mirroring each other, okay? Can we watch earlies? Yeah. Because what's gonna happen as the baby goes in the birth canal? The head's gonna get compressed. So if they're only having a decel with a contraction, we know that they're going back to baseline and they have oxygenation, okay? We know, now, if they're floating and dilated to 2 and having earlies, can we watch those? No, but if they're in the plus numbers coming down in that birth canal, we're gonna see earlies, okay? What are late decelerations related to? Placental insufficiency. These are the worst decelerations you can have. The placenta's way of saying, hey, I'm not gonna hang on much longer, I'm gonna start pooping out or detaching, baby needs to come out, okay? Late decelerations, what are they gonna look like? The nadir is going to happen after the peak of the contraction, okay? And what is a prolonged deceleration?
It's greater than 2 minutes, less than 10 minutes.
It's a deceleration greater than 2 minutes, less than 10 minutes, because more than 10 minutes would be a baseline change. Correct, okay? All right. All right, pain. Pain is going to happen, okay? Anyone who thinks that they're not gonna have pain when they have a baby is delusional, okay? Because what's happening, we gotta get this baby out of the vagina, okay? So expectations, what are their expectations? And I talked about this when I first started, right? Everyone has an expectation of how they're gonna react. If they change those expectations, it's perfectly okay. Also preparation for labor, okay? Making sure that they have an understanding. They should be talking to them at the clinic about preparation and what they're gonna experience. But pain is kind of like fear. You have fight or flight, right? You don't know what's gonna happen or how you're gonna respond to this pain. If you have pharmacological interventions, the pain's gonna get worse because we're making the body contract stronger, right? And so again, understanding. Cultural norms also play a huge role. So as I said before, anyone who's under 18, if they're pregnant having a baby, they make their own decisions. I had a very young 14-year-old who was delivering, and she wanted an epidural, and her mom told her, you got pregnant, you're gonna feel every bit of this labor. You're gonna feel the pain of pushing this baby out, and then you'll never have sex again. And I said, you don't have that right, ma'am. You do not have that right. If she wants an epidural, she can get an epidural. She says, no, I'm her mother. I said, I don't care who you are. If the patient is requesting an epidural, you don't have to say she gets to feel the pain. Where were you when she was having sex is a real question, right? So again, making sure that we validate the culture, but we also have to respect our patient and respect our patient's wishes. okay? Huge issue sometimes. Also, pain is affected, length of the labor. If they're in induction, as I said, and we'll talk a little bit about inductions. If they're in induction, their body's not ready to go into labor, so we have to put their body to get ready. So it can take a while. They get exhausted, especially if they don't know. They come in with their suitcase and they're ready to have a baby, and now they don't even get to 3 or 4 centimeters for 48 hours. That can be exhausting, right? And so again, having those expectations and talking about it. The position of the fetus, we already talked about the back labor, right? That all plays a role. Control, who likes to not have control of their own situation? Nobody, right? So we want to give them as much control because that's when the pain starts affecting them even worse. And support people. I have had to kick support people out before because they're causing more issues than help, and I've asked them to leave. Hey, why don't you go get lunch? Why don't you go calm down? Why don't you go walk to the cafeteria, right? Again, the support person should be beneficial, not ineffective, okay? It's not about them. It's just like when I have dads who get a little queasy, I'm like, sit down, because if you pass out, I am not here to get you. I'm here with her, you're not the patient, okay? So again, making sure we're putting our focus on that mom. So pain is a universal experience. Again, everyone has a different pain tolerance. Non-pharmacological, so continuous labor support. You saw that lady in that video. She was like the most supportive nurse ever, right? Telling about the turtleneck and putting its head through. That's just being there to support them. A lot of times, what's happening in their body? They have a hormonal influx, right? Because their progesterone is withdrawing, their estrogen is increasing, their oxytocin is increasing, their prolactin's increasing because their body is starting to make milk and all of that. And so they may just start crying for no reason. You have to be there to support them through all of it, okay? Bath. So you saw her in the little tub. Now, water births are absolutely disgusting. I will tell you, it's the most disgusting thing. Most women who think they want a water birth will never get through to the end because as they start having intense contractions, you can't have any pain meds in a water birth. You can't have anything. And if you have a water birth, you have to bring your own pool. Maintenance has to inspect it. You have to provide the nurses with gloves that go up to here because we have to go in the water to do badge exams and all of that. And then they sit in their filth, right? They sit in all of that. I know, everyone's like, ew, why would you want that? So I had a patient one time, they told me, Christy, you have a water birth. And I was like, nope, I'm calling off even though I'm here, right? I'm like, nope, I got sick in the parking lot. So I'm like, okay, I guess I have to do this. Because they try and rotate them because they know we all hate them. We don't have many anymore, just because it's so much criteria. And I walk in the room, and not only mom is in the bath, dad is naked in the bath. And he has his legs wrapped around her waist, and he's holding her, and I'm like, well, this is beautiful. I am not here to see men penises, right? I'm okay with baby penises, but I'm not here to have you in the bath. And so I told him it was inappropriate. He's like, well, she's naked. She's the patient. But again, she at least had like a bikini top on and was, naked underneath, but he was completely nude in the bathtub. And I was like, wow, you have a lot of faith in yourself, buddy. So, and so he had to put on shorts to be able to get in the pool with her. But I was like, this is so disgusting. Like, who wants to sit in this, right? She didn't last very long. I think she lasted to 5 centimeters, and then she asked for an epidural. So I was like, pool's gone. My day's better. So definitely, but getting them in the bathtub early on is perfectly fine because it does help relax their body. Ambulation and position changing, those are huge through the whole process, okay? We usually rotate our patients every 30 minutes. We're moving them and changing them, and we have all these great news. There's a new thing out there called spinning babies. We have multiple nurses who are certified in spinning babies now, and it's all these different positions, and you can look through the book when you're there. They have a flying cowgirl where they're like positioned like this. They have all these different ones, and what the research has shown is it helps get the baby in position for the birth process. Again, all of these breathing techniques, all of that non-pharmacological are good. However, they can get batshit crazy. They can go out of hand and different things. Let's talk about the good stuff now, right? All right, pharmacological pain relief. So this is going to be analgesia versus anesthetic. So what is analgesia? That is going to be your IV pain medicine, okay? That's going to be your fentanyl. That's the drug of choice, even though we're in a fentanyl epidemic, okay? What your analgesic does is it first dose is the most effective. So if they're 3 centimeters asking for IV fentanyl, we have a problem because the first dose is most effective and it's very short-lived in their system, in an hour they're gonna need another dose. So we don't wanna keep giving them all this fentanyl, because what does fentanyl do to this fetus? It causes depression, right? So we don't wanna give fentanyl when they're 10 centimeters, because we're gonna have respiratory depression in this fetus. So we have to think about all of these aspects, okay? Analgesics is literally IV pain meds. It doesn't affect anything else other than the pain, okay? We're all good with that, right? First dose, most effective. We don't want to give it when they're about ready to push, because it used to be all deliveries, we pulled Narcan. We had Narcan at the bedside. If baby came out in respiratory depression, we just Narcan the babies. But they found with evidence that's not ideal, so we don't pull Narcan anymore. Again, nursing is all about what? Evidence-based practice, right? All right, anesthesia. So what we use is we use an epidural that goes into the epidural space for vaginal deliveries. If they're doing a C-section, they do a spinal, and that gets more of a relief all around, okay? Epidurals, you put it in the epidural space, and they should still be able to help you move and do different things. Then you have some women who think that they're just a complete wet noodle, and they're like, move me, I'm a princess. And you're like, you're dead weight, and I'm not here to hurt my back. So who do you think you get involved to help move those patients? The partner, right? You're like, hey, partner, yeah, we're good, right? Definitely, because you still have to flip those patients, okay? All medicines do cross the placental barrier, so that's something to be aware of. They do get some of this, okay? So the goal is relaxation. As I said earlier, it can speed up, it can slow down labor, it just depends, okay? All right, so we're gonna talk a little bit about epidural now. So I have a mom, so we know first of all, analgesia, IV med just affects pain, nothing else. Well, it can do respiratory, but usually just in the fetus, okay? Epidural, so your patient wants an epidural, she's in a lot of pain. We know epidurals cause hypotension. So if they're already at a normal blood pressure, we don't want to tank them. So our patients, remember I said let's look at the population. Our patients are healthy usually. I said that yesterday and someone's like, not anymore, we have 6 sick patients. But their body is not a geriatric body, and they can encounter a fluid bolus. So we give 1,000 to 1,500 ml bolus of fluid before an epidural, and we do that so they don't become hypotensive, okay? So could you imagine giving a 90-year-old a 1,500 fluid bolus? No, what would they go into? Fluid overload, pulmonary edema, all that fun stuff, right? So we don't want to do that, but with our patients we do. So we want to get a nice bolus in them, and then we want to pull all of our meds and different things like that. The epidural does affect the baby again as well. Spinal is for your C-sections, okay? Spinals, and then local is going to be what you would do if you needed to stitch up down in the perineum for tears or anything like that. They'll just put local down there. Lidocaine is what they use. And then general, we only use general if we can't get the spinal to work, okay? So we had an older anesthesiologist who, he got to where he was doing this when he would do his spinals, and he poked a patient 9 times trying to get the spinal. The complications of that is a spinal headache, okay? When you have a spinal headache from a spinal anesthesia, you have to have a blood patch. They take blood out of your arm and put it back into your spinal cavity to try, it's a mess. So the more you get poked, the more risk you are of having a spinal headache, okay? Who in here does not get embarrassed by being touched? Okay, come on, Veronica, I'll touch you. All right, I usually pick someone, but last semester I had a student who had like PTSD from me touching her. I was like, oh my God. So now I have to do my little preface. So you're gonna sit right here. Did you have an epidural with your kids?
My daughter.
Okay, you're gonna sit right on the edge.
Oh, on the tip. I'm not gonna tip it.
No, you're fine. You're good. Okay, so Veronica requested an epidural. I'm her nurse, and I just gave her bolus. And now anesthesia says, get your patient ready. So as the nurse, and you guys get to be in epidurals and watch all of this, okay? So as the nurse, my job is to support my patient, get her ready, and make sure she stays completely still while anesthesia is working on her. We work in between contractions, because what's happening? She's gonna have contractions, right? So she lets me know. So as a nurse, what I do is I'm gonna stand between her legs, and she's gonna put her head down, and she's gonna relax her shoulders, okay? So this is how I stand the whole time, supporting my patient. She needs to do like a mad cat, okay? We always say mad cat, put your back out. All right, so I had a patient one time, recently, and she didn't have a really good support person, and so I got her in this position, I'm gonna mess with you, okay? And she instantly put her head in my chest, she wrapped her arms around me, wrapped her legs around me too, and wrapped her legs, and we're sitting like this, and I'm like, okay, and she's like sitting like this through the whole time. And then, so she finishes, and she's like, I'm so sorry, I'm like, it's okay. And so the epidural went in, and they had to go and do another one, and I'm like, let's just do it. Let's just go at it. You can go back, thank you. So again, you see how close, right? She was in my personal space, I was in her personal space, but as a labor and delivery nurse, that's okay. We have to just go with it, okay? So if they wrapped their legs around, she had her legs all tight around me, her arms, she had me so close to her, I was like sweating. I was like, oh my God, this is like too much. But again, I kept her still. That's the goal, because if she jumps, you can get out of that epidural space and you can cause issues. So as the nurse, we have to maintain and support them, okay? And the biggest thing is that fluid bolus so we don't cause hypotension. All right, so with, as I said, with the epidural, it can cause the patient to relax and the baby just comes. Because if they're tense all the time, the contractions aren't doing its job. It can slow the labor progression down, unfortunately, which then we have to give Pitocin and all that. I always tell a patient, if I'm gonna start Pitocin on you or oxytocin on you, and you want an epidural, let's do it before I start Pitocin, because what am I doing with Pitocin? I'm being aggressive and trying to up it to have contractions. So our outcome is a baby, okay? So if they're already in pain or they think they want an epidural and I get an order for Pitocin, I'm like, let's epiduralize you first, because then I can be more aggressive. The best Foley you'll ever place is a Foley on an epiduralized patient, because you can get in there and open the labia and get all in there and they don't feel anything, which is nice. Who's done a female Foley before? They are a lot more challenging than a male Foley, and pregnancy puts an even bigger challenge on it. So I always tell my students, I tell them, think you're a mechanic. And students always laugh, and I have students who come back to me and say, gosh dang it, Professor Wright, once you told me that, I'm like, I can do a female Foley all day. You cannot be on the outer. I love when I walk in and students are like, here's the labia, and they're like, we're gonna open just this much. No, I'm like, you have to see it. You have to see it, you have to be able to. So with pregnancy, what is right here? A baby, which causes what? Extra weight, right? Which causes pressure. So what do you think happens to the urethra? It falls down a little bit, right? So, and your labia gets swollen. So think like a mechanic, and you go in and you're gonna lift the hood. Lift the hood all the way. Can a mechanic do the work with the hood half down?
No.
No. What is a mechanic trying to do, right? What does he have to do? He has to lift the hood all the way. You get in, you lift up and lift the hood, and it will be right there for you, okay? But you can't just go in and open, and I'll stand there if you're with me, because I do my Foleys with my students, and I'm like, I had a student last semester, and she had it just barely labia open, and I'm like, do you see it? She's like, uh-huh. And I'm like, where? And she's like, right there. I'm like, no. I said, that's not it. I said, lift the hood. And she looks at me, and I said, like I told you in class, you need to lift the hood. And so she goes, and again, and she goes just a little bit. And I'm like, do you see it? She's like, uh-huh. And I'm like, no. Thank God this patient was like, had an epidural. Otherwise, we're like playing in her vagina, trying to lift the hood. And so then I always wear sterile gloves. I went, no, lift the hood. And she's like, oh, I see it now. So again, you can be aggressive. It's okay. And you have to be with pregnancy, because everything starts to fall, okay? So please, please, please make sure. I was working a new grad, and we were in there, and she was doing a Foley, and she kept jabbing it at the clitoris. The patient's doing this, and I'm like, no, it's down a little, and the patient's jumping, and I'm like, oh my God, this is so inappropriate. And I was like, no, and she's like, why does she keep moving? And I'm like, because you're stimulating her, like, this isn't, so I was like, right, let's stop. Let's go debrief. So we went, and she's like, I was? And I'm like, yes, that's what was happening. So again, lift the hood, visualize the hole, so you can go in, okay? Especially think about these women too. If they're ruptured, what's happening? You got vagina juice running everywhere, you got stuff, you have fluids, you have blood, you have everything. And so you really have to, it's slippery too, because you have all those fluids. So you really have to get in and lift that hood to get that fold in. All right, all patients with epidurals do get Foley's. So again, that's a good opportunity. All right, nursing interventions, the first stage of labor. Again, the biggest thing here is support, support, support. And hopefully we start getting them to progress. All right, comfort, hydration, fetal monitoring. Precipitous labor is any labor from start to finish is less than 3 hours. That means first contraction happened and the baby was out in less than 3 hours. That's a very long, but it's fast. And in precipitous labors, you can cause vaginal bruising, you can cause cervical bruising, and in the neonate, you can cause facial bruising because the baby's just shooting right out that birth canal, okay? So again, start of labor to delivery, less than 3 hours. Dysfunctional labor, we're gonna talk about because that's gonna be a dystocia, okay? All right, so again, this is no longer called transition. However, it's 8 to 10 centimeters. So you're gonna start having the increased apprehension, irritability, they don't know anything, increased bloody show, they may start grunting, you heard her screaming, right? That's not effective. They're gonna feel pressure, so if they start feeling pressure on the pelvic floor, that tells us that that head is down, because that head is putting pressure on the rectum, that head is putting pressure on the pelvic floor, and all of that. I will tell you, I don't even know if anyone's ever done the statistics. I say 90 to 95% of women have a bowel movement when they're on the table pushing, because they're pushing in the same way as they're pushing out of being constipated. And we tell them, push like it's the biggest bowel movement you have, right? So again, and I did tell you guys the story about the lady who had eaten and had lots of poop. Did I tell you that story? Oh, gosh. So I had a patient, I love my stories, and so, I was in there with a student. And the nurse had a patient. She says, okay, we're gonna start pushing, come in. I'm like, okay. So we go in and I'm standing there with the student. If I'm not busy, I'll stand in there and watch it. I've seen a million deliveries. I don't need to watch them anymore, but I make the students in there. So this lady's pushing and she's just pooping like more than most. And it smelled so bad. And so we were all being appropriate. The student kept looking, and this was before COVID, and she's like, is that normal? I know it's not normal. I'm like, yeah, they poop, but not like that. And so she just kept pooping. And the nurse was cleaning it. You know, we are very discreet. We never say anything. And so I love to share. Sharing is caring. And so I opened the door, because if I'm gonna smell all of this horrible smell of poop, anyone walking by is gonna smell it, right? Because we love to share. And so lots of odors and different things. And so the curtain was pulled, and the doctor, Dr. Barnett, if you've never met Dr. Barnett, he's hilarious. He comes in, he dances in the OR when he does C-sections. Like he plays rap music in there, and we're like, yeah. Anyway, so he comes and the curtain's pulled, and he's like, ew, what's that smell? And I'm like, Dr. Barnett. So I'm on this side of the curtain, the patient's here. He comes on this side, so the patient can't see him. And he's like doing all this, and I'm like, so I walk around the curtain, and I'm like, she's having bowel movements. He's like, God damn, why did you open the door? I'm like, you're about to deliver her, so you're gonna have to smell it anyway. So he walks out and he comes back and he brings me room spray. And I'm like, really? I said, I can't be all spraying the, you know, I'm like, Dr. Barnett. And the student's like, this was before mask even, right? The student's like, she's having a hard time and she keeps looking at me to rescue her, to take her out. And I'm like, nope, sharing is caring. Like, we like to share. So anyways, Dr. Barnett's like, please. And I was like, no, I'm not spraying. What do you want me to do? Spray around her bed? Like, we all can smell it in this room. So finally, and he walks out. He was pissed at me. And so he walks out. So finally the husband's like, damn, baby, what the hell did you eat? And we all started laughing. So, and I was laughing so hard I was crying. Because we all wanted to ask her that question, right? And she's like, stop it. He's like, God damn, baby, you stink. And I was like, oh my God, we laughed. And then she ended up, I said, we have some spray. He's like, yes, please. So I'm like, Dr. Barnett, bring me back that spray. crying, and we all felt bad for her, and then she started apologizing, but I was like, and then after the student was like, was that a lot? I'm like, oh, that was more than I ever seen. Like, that was way too much, but yes. We have one provider who has begged and begged to give all women enemas when they come in so they don't poop, so they don't have to encounter it, and I'm like, nah, we're not doing that. There's no purpose behind it, right? Think of where you're pushing. The rectum and everything is right there in that area. Okay, we already talked a little bit about pushing with contractions. We don't want to push unless the contraction is occurring, okay? During birth, we want to assess maternal and fetal vital signs. However, fetal vital signs is your fetal heart monitoring, pretty much, right? We're going to monitor that heart rate, okay? Fetal vital signs, I hate that it's even on there. We're focusing on maternal vital signs, okay? So again, that's our top priority. If she says the baby's coming, we need to make sure and see, is the baby truly coming? Because again, we got to figure that out, okay? Time of delivery, we want to make sure we know exactly the time. So we go, again, as soon as the baby's out, when you're in a delivery, whoever's there will yell time, and they pull the cord out and they tell you what time on their computer, okay? So we don't look at the clock or anything. It's a lot of communication back and forth, okay? If it's a nuchal, they slip it. We do APGARs at 1 minute and 5 minutes, and we'll talk about APGARs more when we talk about newborns. And then every patient, I say 99 because I never say 100, will get some type of Pitocin after the placenta delivers because we want to clamp that uterus down, okay? Pitocin is given to clamp it down. And then again, we want the baby to the breast. We dry and stimulate and assess. So I already told you a little bit about the placental separation, expulsion. If it's less than 10 minutes, the risk for postpartum hemorrhage isn't there. Greater than 10 minutes, the risk increases. If it gets to 30 minutes, we have to manually get that placenta out, okay? We can't leave that placenta in. We do examine the placenta to see that it is intact, if there's any abnormalities. We do fundal massages. We've all learned about fundal checks, right? You're gonna cut your hand, lower segment, check the fundus. And then we want to assess the bleeding. Again, we have multiple medications in case it's a postpartum hemorrhage. We'll talk about those a little bit more next week. But that's going to be your Methergin, it can be your Cytotec, different things like that. We do want to look at the perineum. We want to assess and see if they need any repairs. If they need repairs, the doctor will do that. Again, making sure that bladder's empty, because what does a full bladder do to the uterus? It displaces it and can cause postpartum hemorrhage. All right, any questions on normal labor? Pretty straightforward.
How does the poop not, like, what if it gets in the baby's eyes or something?
It has happened. You just kind of wipe the eyes out. Yeah. So we have this nurse who is a very mean nurse. No, sometimes you have those nurses. And at one point, she was a charge nurse. And what my story here stays in this room. And so you could have a really controlled environment, and you'd be coaching your patient, and she'd walk in, and she's loud, right? She'd walk in, blah, 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 and I'm like, shut the fuck up, literally, I'm like, come on, we're controlled in here, stop. Anyway, so I had a delivery, and mom kept pooping. And baby had meconium in utero, so baby pooped in utero. Mom kept pooping, so there was a whole shit ton of shit, right? There was just poop everywhere.